The following program is a Town of Colonie television production of the William K. Sanford Town Library.
Well, good morning, good afternoon, good evening, whatever time you're watching this program. My name is Tom Scarff from the Albany County Department for Aging. Welcome to Young at Heart. And today our guest is Dr. Robert Brass from the Brass Eye Center in Latham and Clifton Park, and we are going to talk about some of the problems that people might have with their vision. Not just cataracts, but some other things, but especially cataracts. And Dr. Brass is a longtime ophthalmologist and is happy, I believe, to join us here today. Thanks very much for being with us, Doctor. I have a couple of questions. Of course, we're going to talk about cataracts, and I had both cataracts done. Some people talk about LASIKs and everything. I actually had an operation where they went in and, you know, I was on the table and everything else. Is that normal, or are there other ways of dealing with cataracts?
Okay. Specifically, the cataract is the lens of your eye, and we'll talk about exactly where that is. But in order to do cataract surgery, we have to have you lying down.
Okay.
So typically, we would get some medicine started in your veins to make you nice and comfortable.
Oh, that's nice medicine.
And then we make a little incision on the side of the eye, and we would go inside the eye and remove your cataract. So it's normal to be lying down for cataract surgery.
Okay, so you can't do cataracts with just a laser.
You know, interestingly, cataracts until recently were never done with a laser. It's only in the last few years that a laser's been available. People think it's laser surgery. Now, LASIK, okay, LASIK is surgery. If you look at the eye, this is the cornea. The cornea is the front part of the eye. Inside the eye, behind the colored part, so you can't really see it, but inside the eye sits the lens of the eye. LASIK surgery involves surgery on the cornea, which is the front tissue. Okay. We don't go into the eye, we just change the shape of the cornea. That's LASIK. Cataract surgery actually involves entering the eye, removing the lens, which turns cloudy, and putting a clear implant in its place.
Wow. So, did I actually get a new lens then?
Yes, sir. You would have had a clear implant placed, and we actually measure the power of the implant so we can control whether you can see well in the distance after surgery without glasses, or some people prefer to be able to see up close. And so we can actually cater the choice of the power of the implant to make you either nearsighted or distance.
Now, some people say when they look at me, they'll say, you know, kind of shake their head and say it's like an aurora borealis coming out at them. What causes that little glow that comes out of your eye?
There are certain types of implants that we can use. They're typically made of acrylic. And certain implants have a particular reflex to them. Okay. And that's what people are seeing. They're seeing the reflex, or the light bouncing off of the implant when they look at you. You know when you take a photograph of somebody and sometimes you get red eye?
Yeah, exactly.
Well, in a way, you're seeing a reflex from the light bouncing off your eye. So the implant you had would have been an Alcon lens, because that's the lens that tends to have the reflex.
Okay. Now, and I've never asked this of my doctor, and I'm talking probably 18 years ago that I had the surgery, but what causes a cataract?
Okay, great question. As we go through life, the lens of our eye, which, think of the lens like an M&M, okay? The lens has a shell around it, that's the lens capsule, and it has proteins inside. When we're born, the proteins are perfectly clear, but as we go through life, the proteins kind of get compacted, they denature a little bit, and the proteins get cloudy. So it really is just something that happens naturally throughout life. I always try to avoid saying as we get older. Oh. Okay?
Because I actually wasn't old at the time.
Right.
And I was sitting in a waiting room with all these ladies, and it was the day before I had to get the operation, and I was jittery and everything else, and they asked me what was the problem. I said, well, I'm nervous, I'm having this. And they all told me, sit down and be careful, because it's not that bad. And it really wasn't as bad as I thought it was going to be. It was a fairly simple operation.
It's the fear of the unknown.
Oh, yeah.
Right?
Yeah.
So if you think about the lens, When we do your surgery, we give you medicine in your veins to make you nice and relaxed. So, for example, have you ever had a colonoscopy?
No.
A lot of people, by the time they've had cataract surgery, have had a colonoscopy. The medicine they use for colonoscopy is very similar in that it makes you sedate and comfortable. A lot of times you don't even remember it. And the prep for ophthalmology is nothing like the prep for colonoscopy.
Well, I would hope so. And I would rather have you poking at my eye than any place else, believe me.
So when we talk about the lens, it's like an M&M. I have to make a round opening in the front, okay? And we remove the cloudy lens proteins very carefully. So when we're done with that part of the surgery, we have this little sack, or this, we call it the bag. Imagine the candy coating shell of an M&M, empty. That's where we put the implant. Because a lot of people ask you, where's the implant go? How does it stay in place? So the implant actually is inside your own natural lens, and it stays there.
Now, if you have a cataract, will glasses make a difference?
Absolutely not. Now think about it. You can answer the question yourself. If you have a cloudy lens inside your eye, it doesn't matter what I give you out here.
Right.
Because the problem is inside, so it's blocking your lens. It's clouding your vision.
And how long does the operation normally take?
The typical cataract surgery takes about 10 to 15 minutes.
So the prep is actually, just being prepped for the operation itself is longer.
A lot of work goes into making it sound so simple and straightforward. So there's a lot of calculations and preoperative work. When you're at the surgery center, you can be at the surgery center for about 2 hours or so.
Right.
Because when you get in there, they start an IV. Then they have to get your eye dilated. And then very importantly, we have to get your eye prepped and made sterile, or as close to sterile as possible, so you won't get an infection. But then once the doctor walks in and starts work, the surgery takes about 10, 15 minutes.
I have to say that I remember that when I took the patch off at night, it was like a new world. And that was just hours after I had the cataract surgery. And I don't remember any pain, much, like scratching feeling, and that was it. Was that normal for?
You said you had surgery 18 years ago.
Yeah.
When we did surgery 18 years ago, we used to do an injection around the eye.
They did,
now,
right.
you didn't feel the injection because they probably gave you some extra medicine, made you fall asleep. Currently, I don't even do an injection around the eye, except in odd cases where people just can't hold still. We do what's called topical anesthesia.
Okay.
So just like an eye drop that numbs your eye,
Right.
we numb the surface of the eye with a potent anesthetic, and you're basically lying still, looking straight ahead with no injections around your eye. So after surgery, all we do is put a clear shield over your eye, and you can see very shortly thereafter.
Is that right?
Yeah, it's come a little bit further in 18 years.
Now, where do you do the surgery?
Well, there's a surgery center up in Latham.
Right.
It's across from where Latham Ford is, where the old Starlight Theater used to be.
Up by the Century House, before you get to the Century
Yeah, before you get to it's up Route 9R, the road out to Cohoes.
Right here in the town of Colonie?
It's Albany Regional Eye Surgery Center. It is the best place in the Capital District, bar none, to do surgery, because it's all eye. That's all they do. So pretty much every eye doctor in town is using that surgery center. Right.
So that's a plug for our friends here in the town of Colonie.
Absolutely,
And,
absolutely.
You've got some great medical facilities in the town, and this is now it used to be that, and I don't think they're open anymore. Child's Hospital was a place that a lot of people had their eye surgeries done. That's Albany Medical Center.
Yeah, Child's is part of Albany South, and some doctors still do some surgeries there.
Okay.
But honestly, the equipment there is not necessarily the favored equipment that most ophthalmologists in the country use, and certainly the area. So yeah, we won't really talk about the two different places, because I don't want to say anything bad about Albany Med. It's a great hospital, but the surgery center that we have, we are very lucky to have the most modern equipment in the country. All right, because you mentioned the laser, which we can talk about whenever you're ready, but the laser is not really available everywhere in the country. We are early adapters, and we have some of the greatest technology available right here.
Now, what could possibly go wrong? I have a friend that I work with who had cataract surgery a week and a half ago, and now is having horrible headaches, has had a CAT scan and everything else. doesn't know if it's from the eye surgery or not. Kind of like she said, I have like vertigo, she feels. What can go wrong?
Okay. Well, specific to cataract surgery, because vertigo obviously is a separate issue, typically inner ear.
Right.
But when I talk to my patients about risks and benefits of cataract surgery, one of the key things we think about, the lens is actually held in place by little strings, almost like a trampoline. And as the doctor, when I'm working, every now and then the strings can be weak or a piece of this back capsule can break, and a piece of the lens can actually fall deeper into the eye. Now, if your own natural lens falls deeper in the eye, it's not a problem. But I can't dig for it during the surgery because I would risk causing retinal detachment. So if that happens, we just let it go, we put an implant in, and typically you have a second surgery to get the rest of the lens out, done by one of my colleagues that routinely works in the back of the eye. So if that happens, it's not a problem. It's a nuisance, it's a little bit of a detour, it takes a little bit longer for the vision to come back, but your eye will be perfect as if it never happened.
Is that surgery a little more involved?
Well, when you work in the back of the eye, the risks are a little bit higher for infection or retinal detachment, but honestly, it happens about 1 in 500 cases, and when it happens, it's really not considered a problem.
Is there a genetic predisposition to cataracts?
You know, certain people, certain families definitely get cataracts sooner than others, yes. And racially, that can happen, absolutely.
And as far as other diseases, now I'm a diabetic. And I think he said that
diabetes when it's out of control,
right,
because what happens when your glucose is high,
right,
the sugars in the system will get absorbed in the lens will swell. That will make your vision a little blurry. Then when your sugar comes back to normal, the lens goes back to its normal size. We talked about the proteins getting cloudy. Well, if you constantly are causing this lens to swell and unswell and you're getting all kinds of things going on, you're causing the proteins to get cloudier quicker.
Okay.
Does that make sense?
Yes.
So that's why diabetics can get cataracts more quickly.
Now, but what we really are told to look out for is diabetic retinopathy. Okay,
that's retina. Okay, just like diabetic retinopathy. Diabetes is a disease of blood vessels.
Right.
What happens is the blood vessels can leak. If the blood vessels leak, you get little broken blood vessels with almost like bruises around them. So the area in the where the blood vessels have leaked doesn't work, the tissue doesn't work. And then downstream, because the blood leaked, there's no blood downstream, so the tissue downstream gets hungry for oxygen. So it's like a double whammy. Locally it causes damage, and then downstream it causes damage. So you need to, A, try and prevent retinopathy. If it is found, we can do things with either laser, where we destroy the peripheral tissue, but nowadays we actually have injections that we can do that help to decrease the creation of new blood vessels and decrease the leakage.
So it's not like back 18 years ago where they said there's nothing you can do for diabetic retinopathy.
Exactly. There's tons more that we can do. But
how about macular degeneration?
Well, as far as diabetic retinopathy, the best thing to do is prevention.
Okay.
All right? So you don't want to rest on your laurels that you can let it get worse and have it fixed. Always try to prevent it. Macular degeneration, same sort of thing, exactly. The macula is the center of vision. Now, if you think about the way we see, if I want to look at you, I have my eyes on you, I have my macula on you. I can tell there's things out in the periphery, but I can't see them clearly. If I want to see them clearly, I have to turn my head and put my macula on the object of regard. So you have your central vision, which is your macula, and your peripheral vision. If your macula stops working, if it degenerates, you can't see centrally. Whatever you look at, it's as if you can't see it. So macular degeneration is really one of the more disappointing diseases, or not really disease, conditions to have. It tends to run in families. So if you have a parent or grandparent who had it, you may be at risk of it. In terms of the macular degeneration, used to be there's two forms, dry form and wet form. The dry form is slowly progressive and doesn't involve blood vessel growth. That used to be called the good form. The wet form, wet by the nature of growing blood vessels, used to be the worst form. Because when I was training 18, 20 years ago, we didn't have anything to fix that. But now we have the injections that reverse the growth of blood vessels, that can actually reverse wet macular degeneration. So that's almost the good form now. because we can control that.
So there is hope for anybody.
There is a lot
now,
of hope.
what would be, because our target audience for this program is our senior citizens. What would be the most prevalent disease or condition that would affect seniors?
Well, definitely cataracts.
Right.
Cataract is the leading condition for blindness, or in our country we never really get blindness, but decreased vision. All right. So certainly cataracts would be number one. Diabetes, as we touched on, which is something that's controllable, and then the macular degeneration. Finally, glaucoma.
Right.
Is in there. And glaucoma is a very silent kind of disease because you don't feel the pressure, you don't feel anything, and very slowly what happens in glaucoma, the pressure that builds up in the eye can interfere with the blood flow to the optic nerve, and the optic nerve can die away slowly, so it's a painless loss of vision. So all these things really come down to getting your eyes examined.
On a regular basis.
And it really makes sense for every senior to have an exam at least once a year, especially diabetics and things like that. You know, if it's cataracts, I always tell people it's really very straightforward. If you're noticing you're just not seeing clearly, you need more lights in the room because things seem darker, there's more glare on the road when you're driving, things like that. Typically that can be a sign of cataract. If you're a diabetic, it can be a sign of uncontrolled diabetes, things like that.
When you have the cataract operation, what restrictions do you have afterwards?
You know, it used to be they would...
My father had sandbags.
Exactly. I was going to say, they used to cut the eye open from like 10 o'clock to 2 o'clock, and they used to deliver the lens almost like a little baby. And then they would sew the eye back up, and they would put you in the hospital for a couple of days, sandbags on your head and tell you not to move.
Yeah.
We've come so much further from that. Nowadays, like I said, topical anesthesia. I make a 2.4 millimeter incision on the side of the eye.
Unbelievable.
Okay. We go inside with ultrasound to break up the lens. It's a self-sealing incision. There's no sutures. As far as restrictions, you can go for a walk over at the crossings after surgery if you want. All right. I just don't want you to really exert yourself. So no straining or forcing. It's called the Valsalva. You're like straining, but otherwise, shield so you don't rub or bump your eye because you could pop open those self-sealing incisions. But certainly within a week and after a month, you don't really have to think about it.
But it's not like it was where, you have to wear these god-awful glasses for a week after you have
Typically, the eye shield is for the first 24 hours and then for the first week while you're sleeping. And after the first week, you don't need it anymore.
And what about eye drops?
Eye drops are about 3 times a day for the first week, and then we taper them down after that.
Okay. All right, so let's talk about lasers.
Okay.
Laser surgery, or is it considered laser surgery, or is it laser treatments?
Well, it is using the laser to help with your cataract surgery.
Okay.
All right. So remember we spoke about the lens and kind of being like an M&M. The key thing really is getting a round opening in the front of the lens so that I can gently remove the proteins. But we want to keep that structure intact because that's what holds the implant. Now, I can go in with a little needle, and I'm pretty good at making a round circle, but no human can make a perfectly centered, perfectly round circle.
Of course.
The laser measures all the parameters and makes a perfectly centered, perfectly sized circle. It's called the capsular rhexis. The laser softens up the cataract. And if you look at it, you can see it looks like a little waffle pattern. You know the old Eggo waffles?
Yeah.
They have like a center cuts and then a little, that's what it looks like.
I put too much syrup on mine.
There you go.
One of my problems.
So, because when I go in, remember it's a 2.4 millimeter incision, I have to break your lens up into little pieces that I can then remove. And the laser pre-segments and helps it to make it softer. Finally, we didn't touch on what astigmatism is. Lots of people have astigmatism. They've heard the word, right?
I had them.
Back in grade school, you talk about parallel light rays hitting a curved surface, coming to a focal point. That's in 2 dimensions. In 3 dimensions, you have to be equidistant from the center to come to one focal point. Kind of make sense?
Right, yes.
If your eye is a little oval, Well, these two light rays come over here, these two light rays come here. You're never in focus if your eye's a little oval. Doctors use fancy words to sound really smart. Okay? Astigmatism is just another word for oval. So if your cornea is a little oval, the light rays will never focus. With the laser, we can also correct your astigmatism to give you that much better uncorrected vision.
Now, I remember my mother saying that I had an astigmatism, but I grew out of it. Is that possible?
Certainly. I mean, it's just like any other shape of your body, okay? It could become less of a problem over time. Typically, anything less than 1 unit is not that visually significant.
Okay.
Now, there's another thing about astigmatism. There are implants. When we put your implant in, we spoke about the lens. The standard lens just corrects for distance or for near. But there are other lenses that can correct things like astigmatism. So you have more than the laser can correct. We can actually use an implant that will correct more units of astigmatism. And then there are implants that can give you both distance and near vision. So you would be depending less on your reading glasses. Now, those lenses are not without potential problems. Because they have rings in them, they can cause glare at night. So they're not for everybody. But for the person who didn't grow up wearing glasses, who absolutely hates wearing glasses, it's an option that they should discuss with their doctor.
So if you have the cataract operation and you have the lens implanted, chances are that you're not going to need glasses. The glasses will not help. Your vision should be well enough that you don't need to.
Absolutely. Now, people are not like a mathematical equation. 1 + 1 doesn't always equal 2.
Right.
But I'm very confident getting you in a situation where you'll be able to see very well after cataract surgery. You might need a light pair of glasses if you're driving on a dark night in a storm, or you might need glasses for near vision if we corrected you for near for really small print. But by and large, we can get you to see well without depending on your glasses most of the time.
Now, what about somebody who has multiple problems with the eye? Can you get cataracts and glaucoma at the same time?
You can, and there are procedures we can do that will address your cataract and your glaucoma at the same time. So we can do things during cataract surgery that would allow us to lower the pressure in your eye, either with a stent or putting in another kind of a valve, something that helps to lower the pressure in the eye.
Now, I don't think one thing we didn't speak about are what are the symptoms of a cataract?
Okay. Basically, and again, I like things to make sense, so I don't have to memorize them, right? If the lens is getting cloudy, what happens is you just don't see as clearly. So if you're wearing glasses, you might think they're dirty, but you can't clean them up. Or maybe when you're driving at night, because when your pupil gets larger, right, our pupil gets larger in the dark, it's not a good optical system. Remember back in the day, we used to have a camera and we used to adjust the aperture?
Yeah.
That's the opening. Well, when you want to see distance, you really want a small aperture. But at nighttime, our pupils open up to let more light in, so it's not best for distance. A larger pupil will show the clouding from the lens more, in some cases. Now, in other cases, a small pupil will show the clouding of the lens more. But basically, if you're not seeing well because of a cataract, you just can't see clearly. You can't make out the road signs, and you go for new glasses.
Right.
And it's at that point when, if you go to an optometrist or you go to an ophthalmologist and they try for glasses and we can't get you seeing better, we then look to see, is it a cataract or is it a problem with your macula, with your center of vision? Because every now and then we'll pick up macular degeneration that way.
So you don't hear a lot of people saying, oh, the poor man, he's going blind. I mean, it used to be, back in the 60s and the 50s, it was people were going blind and there was nothing they could do for them. There aren't many diseases of the eye any longer that there's no hope for.
Well, that's exactly right. There are certainly those same diseases, but now we have better ways of managing them. Exactly. Macular degeneration being the one that still is something that we wish we could treat better, because we can't reverse dry changes. When there's dry macular degeneration, which is typically slow in progressing, if it does progress to a certain point, again, you just don't have good central vision. You're never blind, but you really can't see well enough to read or do certain things easily.
So you can arrest it at a certain point, but you can't make it any better.
Exactly.
Okay.
Exactly.
And is that one of the few diseases of the eye that you would say that about?
Macular degeneration is probably one of the most disappointing things right now, but there's new drugs in the pipeline where they're doing investigations on trying to be able to slow blood vessel formation. They're looking at genes and things that they can do to change because it is a genetic condition. It's the cells basically dying away. And so if you could change the genetic predisposition, then that wouldn't happen.
Now I have a question about bifocals.
Okay.
Somebody who has bifocals and they have a cataract, would that take away the need for, there's no bifocal lens that you can get in your eye. I mean,
Well, actually there are, though.
Oh.
We spoke about those multifocal lenses that can give you both distance and near vision.
Right.
They do cause glare at night because what they're doing is, instead of having just one focus, and I don't know if the camera can zoom in on this picture, this actually is a large implant, and it's just a little lens, and it has these haptics on the side that help to hold the lens in place. The standard lens is just one lens, one focus. But there are lenses that actually have little rings in them, and those rings can actually help to give you different focuses at different points. The lens is giving you a focus at distance and near basically at the same time. So when the pupil's very large, that can cause some rings around light and some halos. But that will give you multifocal vision without needing glasses. Effectively, you can only see at one place at one time, correct?
Yes.
So, standard lens, distance. If you want to then see up close, you have to do something different. Get a stronger lens to bring the light in so you can focus up close. That's why we have bifocals. Now, the progressive bifocal, that's the bifocal without the line, really is a better product because on the top it corrects your distance and then it gradually changes to give you intermediate for your computer, for the grocery store shelf, as well as for up close and for reading. The multifocal lens tries to give that, and it does for some people who don't mind the glare at night. But if you're a truck driver or you're doing things at night, if you want crisper, clearer vision, it may not be the best option for you. So there's no panacea. It's a compromise.
All right. So somebody calls you, Dr. Brass, I want to make an appointment, get your secretary. What's the next step? They'll come in for an evaluation.
Right. They would come in, and typically my technicians would help to get them started, and then we get an idea of whether they're nearsighted or farsighted, whether or not we can fix their vision with glasses. Because if we can fix their vision with glasses, then they don't need cataract surgery. Then when I evaluate them, if it is in fact cataract surgery and there's not problems with the retina, that we can make their vision better by removing the cataract, then we go to the next step of actually planning cataract surgery.
Okay. We
We discuss the risks and benefits, which we kind of touched on. You'd asked me what can go wrong. We talked about the lens potentially falling into the back. Whenever you have any kind of surgery, there can be bleeding or infection. And then one thing unique to the eye is the potential for retinal detachment. Now, the retina is like the film in the camera, and it lines the inside of the eye. The eye is not hollow. There's gel, kind of like egg white, inside the eye. As we go through life, the gel liquefies, and gravity starts to peel itself off. Just like pulling tape off a piece of paper, typically the gel comes off and doesn't cause any problems, but rarely the gel can pull and tear the retina. So retinal detachment is something that can happen at the time of cataract surgery as well.
Okay.
But it's very rare.
And it's one of the possible
And we can
problems.
typically fix it as long as we catch it early enough.
And people have to be aware of anything that possibly could go wrong.
Right.
But the chances of that are not great.
It's certainly not a reason not to do cataract surgery.
Okay. Dr. Robert Brass, thank you so much for being with us today on Young at Heart. Dr. Robert Brass is at the Brass Eye Center in Latham and Clifton Park. And a great guy. I learned a lot about something that I thought taken care of 18 years ago, and I'm having a little problem. We spoke a little bit about it before the program, and I'm gonna explore some of the possibilities. So thank you so much for being with us.
Thank
Dr.
you as
Brass.
well. I appreciate it.
I want to give you a phone number, 447-7177. 447-7177. That's the number for New York Connects. Well, New York Connects is a program that the Albany County Department for Aging is very proud to participate in. If you have any problems either you or somebody that you know, somebody that you love, has any problems that they need to have home-delivered meals, or they want to know where congregate meals are, or they need some light cleaning in their homes, whatever, call that number, and that is an information referral center that we have in Albany County that will direct you to the services that you want. So until next month, I want to thank you for being with us today, and hope you'll join us next month for a holiday edition of Young at Heart.